So thank you everyone. I am Dr. Mustafa Aziz Shuman. Welcome you all in our today's discussion. Today's topics: metastatic breast cancer, triple negative metastatic breast cancer.
Okay.
Some technical problem is there. Please pardon. Tanya, stop sharing. Tanya, stop the poll question.
Poll question to share koi nahi.
Okay, let me start from the very beginning. Okay, so sorry for the interruption. Today's our local faculties are Dr. Rubina Sultana, Assistant Professor, Radiation Oncology, National Institute of Cancer Research and Hospital, and Dr. Aditi Paul Chaudhary, Specialist, Lab 8 Cancer and Super Specialist Hospital. So both of them are very bright faces in our
You want to mute yourself?
Suman, we cannot hear you, Suman. Suman.
sorry, am I audible right now?
Yes.
Yeah, it's okay now.
Okay. So today's our topics, metastatic triple negative breast cancer. And today's our local faculties, Dr. Rubina Sultana, Assistant Professor, Radiation Oncology, National Institute of Cancer Research and Hospital, and Dr. Aditi Paul Chaudhary, Specialist Radiation Oncology, Lab 8 Cancer and Super Specialist Hospital. So thank you both the bright faces of our oncology arena for joining. And beside this, we have three distinguished overseas faculties today. Dr. John Conivier, Consultant Oncologist, First NHS Trust, UK. Dr. Mohammad Jakirullah, Consultant Surgeon, Whiptos University Hospital, NHS Trust. So they are very popular and common face over here. And a new face in our board, Dr. Varun Goel, Consultant Medical Oncologist, Rajiv Gandhi Cancer Hospital. Probably he will join very soon. So as a custom, we used to hear a few words from our president, our inspiration, Professor M.A. Heiser. So I would like to request our chairperson, Professor M.A. Heiser, to start the session. Over to you, sir.
Thank you, Shuman. Bismillahirrahmanirrahim. I express my heartiest congratulations and thanks to all of you, particularly faculties from home and abroad, participants, and I'm happy that all of you have joined today. And inshallah, we shall be having good discussion today. Our matter of discussion is metastatic TNBC. So I think without any delay, we should start. Over to you, Shuman.
So thank you, sir. So Tanya, please pose the poll question. Today's first poll question. So I would like to request all the participants please participate in the poll question. So 45 years premenopausal woman. Initially, she was diagnosed with T3N0 triple negative breast cancer. 4 AC, 4 paclitaxel as neoadjuvant chemotherapy given after that surgery, simple mastectomy in axillary dissection form. Pathological T1N0N1 disease, received adjuvant RT and 6 cycles capecitabine. After 1 year, multiple liver metastasis, still it is TNBC. How you will proceed? So for only 3 participants responding in the poll, I would like to request more participation. Okay, still only 3. Okay. So Tania, what is the result? Tania? Tania, can you hear me?
Yes, I
Okay.
can hear you.
So only
Chemotherapy with carboplatin একজন অ্যান্সার করেছেন, আর অ্যাডভান্স ফর BRCA টেস্ট দুজন করেছেন অ্যান্সার।
Okay, so only 3 participants have responded to our poll question. So I would like to request our participants to please participate in the poll. Okay, now I would like to ask the same question to our local faculties, Dr. Aditi Paul. So suppose this is your patient, how you will proceed, Dr. Aditi?
Assalamualaikum everyone. At first, I would like to thank you Oncology Club for giving me this opportunity to speak in this big platform. If a patient with this scenario come to me, I can see this patient was a locally advanced breast cancer, TNBC, and patient got new adjuvant and adjuvant chemotherapy, but there was no BRCA testing was done. So I would like to approach for BRCA testing first.
So, Dr. Aditi, is it your routine practice if a patient with triple negative breast cancers come to you? So usually it is your routine practice to do if they have BRCA mutation status?
No, sir. Routinely, we counsel. We like to counsel this patient for BRCA testing and take the after taking the family history and adequate history. But actually, we don't have adequate scope, and our patient actually every time cannot do this testing. But obviously, I should say we should approach for testing BRCA1/2 mutation test.
Thank you. Thank you, Dr. Aditi. So Dr. Rubina, so what is your opinion regarding this case? Dr. Rubina? Rubina, can you hear me? So you have to unmute yourself, Rubina. Yes, okay.
Yes, can you hear me?
Yes, yes.
Yes. First of all, I'd like to thank Oncology Club to select me as a local participants to give some valuable opinion regarding today's questions. I like to it is a 45 years premenopausal woman, and she receives the 4-cycle CT and paclitaxels, and also the RT and capecitabine 6-cycle. And now she has multiple liver mets. I consider first of all to test the BRCA1 and 2 germline mutations, as it has a role of PARP inhibitor, which can treat the patients like this multiple liver mets.
Okay, Dr. Rubina, Dr. Aditi. So we are talking regarding the real world scenario, but in our routine practice, usually what we are doing. So that is our question. So we should do these things, but actually what we are doing right now.
We do not practice this because these financial constraints, they cannot afford this BRCA1 and 2 mutations, germline mutation testing. And we usually change the chemo schedules.
So what is that? What is
we
that?
Usually
what is that? I want to hear like
carboplatin-based chemotherapy, combined carboplatin-based chemotherapy.
So carboplatin-based chemotherapy, that means that you are thinking about combination chemotherapy. So
chemotherapy that was not used previously.
Okay. So what is your usual protocol? Carboplatin with Dr. Rubina?
Yes.
Carboplatin with. So it is single agent carboplatin or combination chemotherapy?
Carboplatin or combination chemotherapy may be given. That's the gemcitabine paclitaxel can be given, or gemcitabine carboplatin.
So I just want to hear from you, what is your routine practice? Is it single agent or combination chemotherapy?
And I always combined agent, the combination agents.
Thank you. So Aditi, what is your practice?
Sir, usually we practice combination chemotherapy like taxane with platinum, paclitaxel carboplatin, or gemcitabine carboplatin may be used.
Okay, thank you. So now I would like to hear from our overseas expert, Dr. Varun Goel. Welcome. Dr. Varun Goel, can you hear me? Dr. Varun, are you there? Kamal bhai, can you please check whether he is available or not?
Then you move to John. John is there.
Okay. Dr. John, can you please suggest us, so what is your routine practice over there in UK? So what you are doing with this kind of scenario? Dr. John.
Yeah. So normally in the NHS, as she's under 50, diagnosis
Yes.
of early breast cancer. So normally we would have that information to hand. And these days we would now test her for PD-L1 expression on her biopsy. As unfortunately, that doesn't fit in though as option F on the list of options. So, so we test her for PD-L1 expression off the tumor. But out of the options here, personally, I'd consider re-challenging her with taxane-based chemotherapy first line.
Okay. So thank you for your opinion. Zakir bhai, what is your experience over there?
This is very interesting question, because the thing is, of course, you've done neoadjuvant chemotherapy. I was listening to my other colleagues answer, Aditi and obviously Rubina. They practically think about the patients. 1 year after the patient, 1 year after the treatment, the patient came back with metastasis in the liver. I mean, I know we have lost quite a lot of time. Of course, this is important to do BRCA test, but BRCA test normally should be done when you get the triple negative cancer. So your treatment is important now. BRCA test is not going to change any outcome for this patient who has got a liver metastasis. Think practically. That's what I'm just thinking. Okay. Now, this patient, of course, some centers, they normally try carboplatin, but as John said, that he will challenge with further docetaxel or different types of docetaxel to see what's happening. But I think definitely the liver metastasis, different oncologists are treating it a different way. But in our United Kingdom, we always do PD-L1 study to see whether there is anything actually positive or not. So my experience, of course, I'm not an oncologist, but when we sit down in MDT meeting, I've seen consultants are actually challenging each other, but nothing is wrong as long as you have a rational answer. Why do you want to do that? That's my experience.
So thank you, Zakir sir. This is the ISO International Consensus Guidelines for Advanced Breast Cancer, ABC5. They've said they don't have any preference over any specific chemotherapy because we don't have enough evidence on triple negative breast cancer. So they at last concluded that any drugs that is applicable for HER2 negative disease that can be tried within triple negative breast cancer. So these are all the options for chemotherapy. So all we are agreed that we are going to treat these patients with chemotherapy, except John, because he is in favor of PD-L1 test. And we are coming in that issues later. So you could see that all of these drugs are available there. But the key message over there, that if the patient doesn't have any visceral crisis or rapidly progressing disease, the treatment should be in sequential monotherapy, not in a combination chemotherapy. Only combination chemotherapy should be applied when the disease is rapidly progressing and you are thinking that you are going to lose this patient within a few days or within a few months. Then at only these circumstances you can consider this combination chemotherapy. Otherwise, single agent sequential chemotherapy is the preferred option. So these are the NCCN guidelines. You could say all the drugs are available there. You could choose any drugs in sequential therapy. Now, I would like to ask the question to John. So, Dr. John, as the TNT trial showed that the carboplatin versus docetaxel, irrespective of BRCA status, you could see that these are very equal outcome with lesser toxic use carboplatin. So still you are in favor of Taxane. Why? Dr. John.
So I'd say the weekly Taxol tends to be better tolerated. You can use cold cap, they can protect their hair. And these days, again, we've moved in our practice on the basis that PD-L1 Taxol in combination with immunotherapy. So that would be the current option in the UK. The other thing to say, it describes multiple liver metastases, but if she had 3 or less, as there's a year's gap between her completion of curative treatment and relapse, in the UK, she'd also potentially have the option of radiotherapy for oligometastatic disease recurrence. So we'd also consider her for saver to treat her liver disease, and then afterwards give her chemotherapy. That's also worth considering.
Okay. So regarding our socioeconomic status, so Taxane is comparatively a costly drug than platinum. So do you think after this TNT trial, it would be a reasonable idea to treat our patients with carboplatin upfront?
Absolutely. Ultimately, she's never going to be cured. So whether you give platinum, taxane, capecitabine, she's probably, unfortunately, if resources are an issue, then maybe they won't. But in the UK, they'll have a sequence of chemotherapy that's likely to include all those agents in some sequence. So I think it's entirely reasonable, if it's cost driven as well, that you use the cheapest, most effective drug that they can afford.
John, can you kindly go close to the microphone, because it's actually interrupted. I can't hear you properly, if you don't mind.
Okay, I think that this is my network problem. So I also find it very difficult just to hear from you, John. So can you please come forward close to your microphone?
Yeah, so can you hear that better?
Definitely much better. Definitely much better.
Yes,
yeah.
yes.
Okay. So I was just saying, so in the UK, we also have funding now for patients who have oligometastatic disease at relapse. So I know it mentioned in this lady's case multiple liver metastases. If she had 3 or less, though, she could be considered for stereotactic ablative radiotherapy to treat her liver disease. In terms of systemic therapy, then it does seem entirely reasonable to use the most cost-efficient drug in her treatment. And so if cost is an issue, then yes, using carboplatin single agent seems entirely reasonable. Ultimately, though, her disease is incurable. And so whether the sequencing of her drugs, she's likely to hopefully receive a taxane, platinum, and capecitabine at some point in her care. And so if you use them in slightly different order, depending on cost availability, that seems reasonable to me.
Okay. So Dr. Varun Goel, can you hear me?
Yes, yes.
Yes. Okay, so thank you for joining. So we are discussing regarding the chemotherapy sequence in triple negative cancer. So the patient initially treated with 4-AC, 4-Taxane. After that, she was treated with capecitabine, and unfortunately, after 1 year, she developed liver metastasis, and still it is triple negative. Now, in your setup, what would be your routine practice, and what would be the sequence, Dr. Borin?
So, as you were told that taxanes have been given 1 year earlier. So,
Yes.
And so if patient is not having significant neuropathy, we can again re-challenge with taxanes. Otherwise, eribulin is a good option this time, because you are told that this is TNBC only. So we don't have any other option, chemo only. So, and I will try to add platinum also this time. So if dosi cis or dosi carb, combination if patient PS allows. Beside that, obviously, we are also prescribing and referring for BRCA mutation testing and PDL1 and MSI testing. And if PDL1 is high, we can offer IO agents. If BRCA is mutant, then PARP inhibitor can also be offered upfront.
Okay, so in general, in Indian context, are you in favor of doing BRCA test to every patient? Is it your routine practice, or there are some selection criteria for this BRCA test?
Yes, so it is like if patient is TNBC, if younger patient, if there is significant family history, then we usually go for BRCA testing upfront. Otherwise, if in other patients, also can be offered, but not upfront. Maybe after 2-3 standard lines. And still, if patient is progressing, then we order for that. Okay. Otherwise, in TNBC younger patient, we should order upfront.
Okay, thank you, Dr. Varun. So stay with us. We are coming to you within a short time. So you could see that that ABC5 consensus guidelines shows that in triple negative breast cancer, previously treated with anthracyclines with or without taxane in the neoadjuvant setting, carboplatin demonstrated comparable efficacy. So we can think carboplatin, particularly in a resource-constrained country like Bangladesh. As you know, taxane is costly drugs. So we can think after the TNT trial, so it is going to give you a comparable efficacy. So there are several times this question comes, the BRCA test. So from our local faculties to the overseas faculties. So these BRCA issues severely coming in our discussion. So now the question, I have already asked this question to Dr. Varun Goel. Now to Dr. Ruvina. So would you offer BRCA test to every TNBC patient? And would you treat differently if BRCA found mutated? Dr. Ruvina. Dr. Ruvina? Okay, Dr. Aditi, you can take over. By this time, Dr. Rubina may join.
In our country, actually, we can't offer BRCA testing for every patient, but if a patient has a strong family history and patient was initially TNBC and in this patient, they again IC came to TNBC. So before starting chemotherapy, in this type of patient, strong family history and TNBC, I would like to do BRCA testing, and I would like to offer patient BRCA testing, and if it is possible. And another thing, there are certain types of TNBC. In basal-like TNBC, 80% cases, there is BRCA mutation is positive. So that if I can know which subtype of TNBC it is, I can offer BRCA testing more confidently. And
if BRCA comes positive, suppose it's BRCA1 positive, what would be your practice?
If BRCA test positive, I would like to offer olaparib for the patient for his next treatment.
So in first line, if it is BRCA positive, so in first line in metastatic setup, you are in favor of PARP inhibitors, right?
Okay, yes, sir. I'm in favor of PARP.
Okay, Dr. Ruvina, are you there?
I cannot. Yes.
Okay, Dr.
Yes,
Ruvina,
yes.
I think you need not to unmute yourself.
So now I can.
Okay.
Yes, yes.
So
Can
okay.
you hear me?
So
yes.
Yeah. So the BRCA test. So the BRCA investigations requested by Dr. Aditi Paul, and it comes positive. So it is BRCA1 positive right now. So how you are going to treat your patient right now?
If the BRCA1 mutation, germline mutation is positive, then I will prescribe the PARP inhibitor. This is olaparib. Can I prescribe?
Okay. So the similar type of answers over there. So Dr. Varun Goel. So are you in favor in using PARP inhibitors as first line in BRCA status positive patient?
we can offer, but we have to see whether a patient financial status and burden of disease and PS. So if as you told that patient presented with liver mets, so if burden of disease is too much, then I will try to decrease the burden initially with chemotherapy, and then as a maintenance we can offer olaparib, and if burden of disease is not too much and there is no financial constraint, then we can go for BRCA mutation, like in BRCA mutation positive patient olaparib. There is no.
So thank you. So Dr. John, so BRCA status positive. So right now we have evidence. I am going in my next slide. That is the mBRCA trial. I could see that the Olympiad and mBRCA, most of them are tried more than third lines. So here all the faculties are in favor of using these PARP inhibitors as first line. So what is your suggestions, Dr. John?
Yeah, so in the NHS, we don't.
Dr.
So
John,
in
we
the
can.
NHS, we don't have access to first-line PARP patients, olaparib. So can you hear me now?
Yes. Right now it is clear.
So we don't have access to olaparib first line. So we offer platinum-based chemotherapy. So PARPs aren't available yet routinely on the NHS.
So you will treat your patient with chemotherapy, and in subsequent phase, is it available in later lines, PARP?
Not currently, no.
So PARP is not available over there, right?
Hasn't been despite the results.
John, I don't know, your line is very bad today, but olaparib, can you treat your private patient with that, John? Forget about NHS.
So olaparib, yes, but not first line.
Right.
Okay. So just go back to our few earlier slides. You could see that as per the NCCN guidelines, the germline BRCA mutations is suggested to do in all patients with recurrent or metastatic breast cancer. And it is very similar with the ESMO guidelines also. So they are suggesting to do BRCA status for all patients. And in BRCA status positive, again, they suggest to try with a platinum agent. So we have already discussed the Olympiad and BRCA trial, and this, you could see the progression-free survival is there. But most interestingly, that the PARP inhibitors do better when it gives earlier. So you could see that when you give olaparib, no prior chemotherapy group, the overall survival is 20 to 6 months. And when you have given prior chemotherapy, the overall survival is 18.8 months. So from this trial, it shows that if you want to treat your patient with PARP inhibitors, probably it is better to give it earlier. So there is a question regarding these two agents, platinum and PARP.
I would like to go for inhibitor. So I would like to use it earlier.
Okay, so if you
it's a PARP inhibitor.
okay, Dr. Rubina.
I also, if there is an availability and if there is no financial constraint, I will first choose the PARP inhibitor.
Okay, so these are very costly options, and both our local faculties are in favor of using this PARP. Dr. Varun, what would be your take? Platinum or PARP? Which one?
So I have a different opinion because I will try platinum-based chemotherapy first to decrease the burden, and as I've told you that this is less costly and easily available, and most of the data we have with that. And as you have shown these two important landmark trials, even in those, this drug olaparib have been given in the second line or later lines. So initially, I would try with the platinum, and then on progression, or if after platinum drugs still significant disease is remaining, then obviously I will offer for
Okay. So Jakir bhai, what is your experience over there?
This is becoming much more difficult now because, as I said, when we sit down in the oncologist, exactly a similar kind of response we actually get from different oncologists. Some of them in favor of platinum-based chemotherapy because that's cheaper. At the same time, if there is no toxicity, as we mentioned, from the previous platinum used or anything like that, then this is probably the safest option to see whether they can debulk or they reduce the load in other metastatic areas. But of course, I'm a surgeon. I just watch. I cannot contribute anything much more than that. But it's a debatable. But we can see some sort of changes happening now. But triple negative is very difficult to control. As John said, the triple negative we normally try to go for immunotherapies nowadays, and PD-L1 study is done for every one of the patients now. Is a part of the trial, and at the same time, it's actually showing some remarkable results. So we are probably inclining into that area after other chemotherapy is exhausted for use.
So thank you, Jakir bhai. I have got opinion from Dr. John because he has already mentioned that they don't have any facilities with the part. So definitely his answer would be platinum first. So I'm not going in that question. So this is the summary. You could see that it is unknown how part or platinum, which one should be first, but we need broader study. Right now, these are all are equal in outcome. So now I would like to ask Dr. Ms. Tania to please pose the second question. Dr. Tania, can you please pose the second question? Tania, can you hear me?
Yes, sir, I can hear you.
Okay, last time a few participants write in the chat box, so they are not put their answers in the chat in the poll. So please check that issue.
Yes, sir.
So this is 45 years. Yes, T3N1 M1 bone metastasis disease. So how you will proceed? It's a very simple question. Consider you are practicing in Bangladesh. Okay, stop the poll. So a few answers are in RT2 painful site, chemotherapy zoledronate, and two very intelligently answered repeat IAC. So I'd like to ask the question to Dr. Aditi. So what would be your take? So which one you will prefer?
I would prefer to do the immunohistochemistry again. This patient is a TNBC and developed multiple site bony metastasis. So in case of TNBC, we usually, when patient comes with metastasis, usually we find visceral metastasis first. So if it is every time when before proceeding any treatment for metastatic disease, at first we should reassess for the immunohistochemistry. In our country, in our constant, obviously I would like to do the immunohistochemistry first for proceeding any kind of treatment.
So you are not very confident with the immunohistochemistry. So you want to repeat your test.
Yes,
so you want to depend on your clinical judgment. Very good. Dr. Rubina?
Yes. I also repeat immunohistochemistry because there is no other visceral crisis or visceral metastasis, only bone mets. So it's likely the immunohistochemistry will repeat if it is TNBC or not. Yeah, it is only ERPR positive. Maybe it is ERPR positive. And if immunohistochemistry repetition and then RT2, consider the RT2 painful site with zoledronic acid and single agent chemotherapy as there is no visceral crisis.
Okay, so we are not focusing in that issue. So here my intention is to see
Yes,
whether we are going for repeat
always
immunohistochemistry or not.
repeat immunohistochemistry.
Okay, so you could see that these are more than 3 lakhs patients, triple negative breast cancer. The most common sites, brain is the most common site. Later on, liver, lung, and bone is a very less frequent site. So we should just with clinical judgment. And in Bangladesh, I will jump to question to Dr. Zakir Bhai first, then I will come to Dr. Borun. So Zakir Bhai, here in Bangladesh, we are in a very critical situation. We are very frequently we are getting triple negative breast cancer. That doesn't correlate with our clinical judgments. So what your decision or opinion in that issues?
I mean, as I mentioned earlier, when I was doing some sort of little bit of study with Bangladeshi patients, I found almost 40% of Bangladeshi people are actually triple negative. That's huge number. In the UK or other areas, naturally, we know that's about 15%, the maximum 20%. So first of all, I did mention to you before as well that whether this is tissue sampling is really properly done or not, because sometimes if you delay processing this tissue or keeping the tissue in formalin takes 2-3 hours after your operation, that can delay the status, the ERPR and HER2 status as well. So in Bangladesh perspective, of course, the answer I've heard from Aditi and Rubina, I'll probably repeat, of course, they're right. If there is any metastasis just to see immunohistochemistry is different than what you have actually discovered before or not, before starting any new treatment. So, but of course, it's causing some sort of money constraint problem as well in Bangladesh. It's not like any other countries, developed countries, you can do whatever you like. So you have to justify doing anything. And in my response would be each and every patient is different, and find out what is the best way to go ahead. And if there is no way of you do repeat immunohistochemistry, then obviously monotherapy, whatever you're discussing, is the best option for this patient.
Thank you, Zakir Bhai. So Dr. Borun, so what you would do in this kind of situation? So would you? Yes.
I also agree with my other panelists, other faculty and colleagues that because there are bone only disease, there is no visceral mets, and so in any case we have to do repeat ISC just to confirm that it is TNBC only. Because if even 1% ER positivity is there, we can offer just CDK inhibitor and all, and that is very important parameter. So repeat ISC should be done, and after that, obviously chemotherapy, as we have discussed, with platinums, with or without zoledronic acid, and if painful bone mets, then radiation can be offered.
Thank you, Bala. Dr. John, I know that you are not in this type of situation, but what would be your suggestion if you are practicing here in Bangladesh? What you are going to do, Dr. John?
I think John is actually on holiday, so he is trying to join from a center where obviously reception is not great, but he's going to come back, he said.
Okay, no problem, Zakir Bhai. Then we will proceed to our next question. Dr. Tania, please pose the third question. So it's a metastatic disease, immunohistochemistry ER 2/8, PR 2/8, HER2 negative. How you will proceed? Okay, so 43% are in favor with endocrine therapy like treatment, ovarian suppression, CDK4/6. Only one respondent in favor of tamoxifen, and 44% would like to treat her as like TNBC. Okay. So at first, Dr. Aditi, what would be your opinion? ER low, PR low, hard to negative.
This patient has very low ER and PR positivity. So they are less likely to be respond against the hormone receptor positive. If we treat her like hormone receptor positive, there I think there is less possibility to respond. So I would like to treat her as TNBC.
Okay. Dr. Ruvina?
Yes, I also go with Dr. Aditi. As we know, the ERPR scoring, this is the 1 to 10% positive, is considered as a low positive receptor. So I consider this is a negative, and I treat this like a TNBC.
So you are not considering her with any kind of endocrine therapy. Suppose
No.
you are giving her chemotherapy first. So after completion of chemotherapy, are you going for endocrine therapy?
Now I think the hormone receptor as a low, I consider this is likely to negative, and no tamoxifen or other drugs will work with this.
Okay, so Dr. Borun, what would be your suggestions regarding this case?
So first of all, I would like to know that whether this liver disease is like patient is in visceral crisis or not. So 1 or 2 liver mets may be there, but if patient is not in visceral crisis, so we can treat it as a ERPR positive patient. So because if we are going to give CDK inhibitors, within 3-4 weeks, patient will respond. If not, we can obviously go for chemotherapy then. Otherwise, if patient is in visceral crisis or there are many liver lesions and causing liver dysfunction in blood test, first of all, we have to go chemotherapy, and then we can switch over to CDK inhibitors.
Okay.
So in any case, even 1% ER positivity nowadays should be taken as ER positive as per definition. So it's depend on burden of disease, chemo first, followed by CDK inhibitor, otherwise CDK inhibitor after.
Okay, Dr. Borun, in this context, as per the last 5 consensus ABC guidelines, you could see they have included this low ERPR group, that means up to 10%, in a sub-classification. They called it as orphan subgroup. And they suggested that it should be considered as patient like triple negative breast cancer. So what to do? This is a real type of complex situation. A hormone positive is there, but here in the guidelines they are saying you have to treat in a triple negative breast cancer. What?
So for trial purpose, it may be like that, but still, in the first line they have written that endocrine therapy exclusively. So we are not treating it with just endocrine therapy. So I am not going for tamoxifen alone or AI alone, ovarian suppression with AI. So I would like to give AI, ovarian suppression, with CDK inhibitor. Because we have rich experience with CDK inhibitors, and we have seen very good results, good responses in even in low ER positive patients also. Obviously, if ER positivity is higher, then there will be better response. So that's the reason I'm saying that if patient is in visceral crisis, then we don't have that much time to see the assess the effect of CDK inhibitor. In that case, we should go for chemo first, and then we can switch over to hormone therapy.
Okay. So, Dr. John, can you hear me?
Yes.
Okay.
I would treat it as triple negative breast cancer.
So we need your support in this really complex situations. So low ER, low PR, hard to negative. What to do? Hormone therapy, chemotherapy, or combination?
So again, our standard of care at the moment is to treat as triple negative, screen for PD-L1, and give chemo IO if they're PD-L1 positive. If they PD-L1 negative, we give chemo again, and normally we give single agent taxane-based chemo.
So you are not considering it as an
CDK.
endocrine responsive disease? Okay.
No, I wouldn't.
So that is really a very good area of discussion. So I think we should
Can
jump
I
to our next question because
can I add
John,
one?
yes, please, Jakir bhai.
Sorry, I'm a surgeon, but I think as a surgeon, what I've learned from our MD team, any scoring below 3 for ER/PR is negative. So, I mean, I think in this question, there's slight mistake that it's ER positive 2 out of 8. We never actually said that ER positive. We always said the scoring for ER is 2 out of 8, or PR is 2 or 3 out of 8, whatever it is, and then we say negative at the end. So the question is slightly deviating us as if ER positive 2 out of 7. That might be the confusion, but we always treat anybody below the score of 3 is negative here, as a surgeon that I understand.
So that is a very new information, Jakir bhai. Here in Bangladesh, they used to report like this: ER positive, score 2 by 8, PR positive 2 by 8. We used
That's
to get
confusing.
this sorts of,
That is the confusing.
yes.
We do
So
scoring, and at the end we say this is, and then low positivity, we say anything about 3, 4, 5 is low positivity, but of course above 5, 6, 7, 8 is a positive. That's I normally can consider here.
So thank you, Zakir bhai. So here in my last poll question, so that is related with the IO. You could see there is the PDL1 score is more than 10%. So how you will proceed? So you have got 5 answers till now, and all of them are in favor of A2 plus nab-paclitaxel. So I think it is more than 1 minute. So we can close the poll. So Tanya, you can stop the poll. So again, my question to my first local faculty, Dr. Aditi. So PDL1, 10%. I know we are not in a position to use frequently in this sorts of costly medicine. So from academic discussion, so how you are going to treat your patient with Ato or Pembro?
Actually, I think we can use any of these options, atezolizumab with nab-paclitaxel or pembrolizumab with paclitaxel. We can use either one. If PDL1, if we have option to use these drugs, as this patient is PDL1 more than 10% positive.
So which one, Ato or Pembro?
Actually, both the drugs have significant survival benefit in the studies as far as I have seen. So I'm actually a bit confused. Is this question?
Okay, fair enough. Okay, Dr. Rubina, answer A or B?
I go with pembrolizumab and paclitaxel, nab-paclitaxel or paclitaxel, or combination of gemcitabine carboplatin with pembrolizumab.
Okay. So Dr. Borun, regarding IO.
Yes, any IO can be given, Atezo versus Pembro, but data is more with Atezo with nab-pacli, and our experience also with. So I will go with Atezo plus nab.
Thank you. Thank you, Dr. Borun. So what I'm going to show right now, you can see this is NCCN guidelines version 7, 2021. You could see that triple negative breast cancer, they used to test the PDL1 biomarkers. And if it is more than 1%, they advise for atezolizumab plus nab-paclitaxel. And another option is there, if the CPS score is more than 10%, pembro plus chemotherapy. So both options are valid as per version 7, 2021. So this is the I'm patient 130. Based on this study, this guidelines was updated, and you could see the progression-free survival, and the median progression-free survival was around 2 or 3 months benefit, 5 versus 7.5 months. That is the PFS. And you could see that the overall analysis over the intention to treat population, it is not significant. So this is a very interesting paper published in August 28, 2021. So this is the Roche declared they're going to withdraw their indication atezolizumab, particularly for TNBC patient, and it was on August 28, 2021, because finally they failed to prove any OS benefit in this subclassification of group. So atezolizumab plus nab-paclitaxel probably not a very good selection idea for in this sort of patient. So you could see I have seen that version 7 2021, you could see the red line mark, ATO and nab-paclitaxel is there. Here you could see the red mark. This ATO albumin bond nab-paclitaxel is not there. So they have withdrawn their indication in this scenario. So now we have only if the PDL expression CPS score is more than 10, you can consider the pembro. So atezolizumab probably not a good idea for selection in this context. So here we do have the keynote 355. So right now we have only pembro that based on this 355, and you could see that is the pembro. The CPS score, if it is more than 10, you could find some difference over there. And in PFS, it is also there. So regarding this issue, Dr. John, what is your suggestions? So from the beginning, you are in favor of PDL1 test. So now what you are going to teach your patient if the PDL score is positive, ATO or pembro?
So the moment we have access to NAB, Taxol and Atezo currently with NICE, interestingly. So it hasn't been withdrawn yet from the UK for treatment of patients, but based on the data, it would seem to suggest that pembrolizumab is the optimal way forward. But again, the NHS hasn't allowed pembrolizumab to be available instead of Atezo. So in terms of our patients in our country at the moment, they only have access to Abraxane and atezolizumab. But yeah, that's essentially where we are. And also, you know, Peter, who ran the trial, works with me in our center. So his feelings, he's still very positive towards the idea of PD-L1 positives receiving immunotherapy first line with chemotherapy.
So regarding this trial, Dr. John, I would like to seek your attention. You could see that unlike the natural IO trial, you could see here in this green line, blue line, here hardly you could find any tail. That is very commonly seen in the lung or in melanoma trials. So still it is missing here there. So still you are in favor of this atezolizumab.
Yeah, so I have to say there's clinical pay. You know, I appreciate there's no tail, but there are there's patients who I've seen treated who've done exceptionally well on it. You know, anecdotally that doesn't explain the trial and the nuances of why the trial is, why that's happened. Again, it's difficult to say. It's the same with Atezo and Taxol. You know, the study was negative, and so again, I think it's a story that's still playing out, and hopefully will be explained as we understand better the immunogenicity of the disease itself. You know, why that's happening.
Okay, so Dr. John, so for our suggestions, so you know, here in Bangladesh, the patient has to buy their own pocket. So he has to spend everything from it. So do you think after this withdrawal of the indication and the NCCN, they have also withdraw their suggestions. So do you think in Bangladesh it is wise to suggest ATO and nab-paclitaxel in this context right now?
So I would probably, the fact that Roche has withdrawn Atezo after discussion with the FDA, I would probably stick to guidance. And if NCCN still includes pembrolizumab as an alternative to PD-L1 10% positive patients, I would go down that route instead, personally.
So thank you, Dr. Zakir Bhai. Do you have anything to add in this scenario?
That's very debatable because, of course, it's a financial crisis, and also at the same time, you're thinking about newer drugs and newer possibilities and immunotherapies, which now you're declaring that it's not working very well. It might take a little bit of time because some individual people when they're treating with this particular kind of immunotherapies or chemotherapies, they did show some response. So it depends on your own practice. If you find it's a good response with the particular medications, then probably continue rather than stopping it abruptly. But we are going to see of course, the company has withdrawn. It's a difficult situation. So as a surgeon, honestly, I don't have much opinion about that. I leave it for you to debate.
But the real problem is that after that I am patient 130. Some patients, though I don't have, fortunately I don't have any patients, but some of our colleagues treated with this protocol, and they found that some good response are there. So what they will do right now?
Continue.
So,
I will say continue. If you get a good response, there's no point of stopping it, because you have seen in this particular graph you showed us that some of the patients are actually doing fine. It's the overall results is showing that there is no real benefit. That's what they decided. But if it might be individually, some patients have got better response compared to others because everybody is different. So my suggestion would be, if you've got a good response, continue. I believe most of the oncologists will believe that.
so thank you.
Just to add one comment. Obviously,
yes,
patients have shown response to Atijo and Napaki. So just on the basis of NCCN change, we should not stop that. But there is one more issue. So if that collaborate with the company policy, like because initially maybe because of the approval, patient is getting patient assistance plan from the company, I may say Roche. But if because of the like loss of approval, like NCCN have not given approval now, so maybe patient assistance plan will not be given. If that is the case, we can change. If the company is continuing with that, then we can continue same drug.
Okay, thank you, Varun. Thank you for giving insight in another area. So I am at the end of our presentation. So I am not going in details in our every faculties. I would like to hear straight away from Dr. John. So what's your opinion regarding this sacituzumab govitecan in second or third line TNBC patient, metastatic TNBC?
Really exciting. So waiting for it to arrive on the shores of Britain. So it's available privately for patients, and I haven't personally used it yet, but I know colleagues who have, and they've had good responses so far in heavily pretreated triple negative patients.
So this is very interesting findings, John. You must say that the median overall survival, after second or third line, you could see the overall survival more than 1 year. So this is very exciting drugs right now coming in our hand, right?
Absolutely, yeah.
So Dr. Varun, do you have any experience regarding these drugs?
Not till now, not available in India, right?
Okay. Okay, so just for academic discussion, so it is really a good drugs coming in our armamentarium to treat TNBC metastatic setup.
Yes, obviously.
So
these results are very promising to look, and obviously we will wait for approval and available PO3. We will definitely give try to these drugs.
Okay, so let us summarize today's discussion that as per the ISO-ESMO ABC 5 guidelines, there is the updated guidelines. If there is a triple negative breast cancer, they have said to test BRCA status in all patients. In 2, they have requested to do the PD-L1 test, but I think in Bangladesh context, this area might be controversial, but we should try to do BRCA status because it helps to guide our treatment. So if it is PD-L1 positive, they are in favor of IO with chemo combination. If they are not BRCA mutation, they think for PARP or Taxane, and otherwise they have advised for sequential chemotherapy, single agent. And if the visceral crisis is there, they advise for polychemotherapy. And of course, the FDA approved sacituzumab govitecan more than second lines. So these are all from our today's discussion. Let me take some question from the chat box. Dr. John, in oligometric disease, several potentially this chemo could be delivered. And this is okay, this is a suggestions. from Dr. John. Later BRCA positive case, all patients were platinum sensitive. What could be the reason or different result of trial with atozo in metastatic TNBC, just changing the NAP tactics? Or oh, this is a very interesting question. I would like to hear from Dr. John. So I am patient 130 using NAP paclitaxel, they found some progression-free survival. But when they treated in 131 with paclitaxel, they didn't find any difference. Why? Dr. John.
So that's a really good question. And my understanding is that there was, well, having spoken to Peter Schmidt, the feeling was there was imbalances in the arms in which patients were selected. So the trial design he was critical of, but nonetheless, the trial was negative and overturned a lot of trials that Roche had planned. So it's obviously caused a real fly in their trial ointment for immunotherapy plus chemo. So I don't know the reason why. There's conjecture in terms of it was based on study design and patient selection, but I'm sure it's much wider than that in terms of whether or not nab-taxol is in some way immunogenic. Like I think last week we talked about antibodies being in some way immunogenic. I wait to see how the story plays out myself.
But interestingly, if you can see that the keynote 355 in Pembro, they have used gemcitabine, they have used paclitaxel, and they found some difference. So it is happening only in atezolizumab case. So that's very interesting. So Dr. Varun, would you like to enlighten ourselves in these issues?
Yes, like we have discussed earlier also in different platforms, like clearly there is no answer for that. So just maybe, as Dr. John have pointed out, some patient population difference, some trial design difference, maybe, but clearly there is no answer.
So Dr. John, please.
I know we're talking about breast cancer, but again, anecdotally, I'm sure you will have seen data in the lung cancer space, which suggests that patients who've been exposed to immunotherapy for lung cancer then seem to have a much higher response rate to taxane-based chemotherapy in the second or third line. So I know Boehringer Ingelheim has data that shows docetaxel response rates in the 30% post-IO when the original study showed 10%. So there does seem to be some potential biological signal there between immunotherapy and taxanes. What that is, we wait to see.
So thank you, John. So I am at the last. So next topics would be very interesting. I must say that the fertility, breast cancer, and pregnancy, this is a very burning issues, because in our country we are getting a very young age group, and moderator will be Dr. F.M. Kamaluddin sir. So that's all from me today. And now I would like to give a special thanks to all our faculties, both local and overseas, for giving their precious time. May I request our academic secretary, Dr. F.M. Kamaluddin sir, to say a few words regarding our today's discussion. Dr. F.M. Kamaluddin sir.
Thank you, Shumon. It was quite exciting, and as expected, TNBC is the area of discussion and debate. So we had that, and I'm very happy to see. I would rather say happy that even after so much discussion, we did not bring many conclusions, because TNBC is the area where still we cannot conclude many things. But I think it was eye-opening for many of us, and the message that was given is very important, that we need to stick to the guideline and follow always whatever is recommended by the guideline. We should not go off the guideline. And when TNBC is there, I suggest personally that we should be sharing with each other's experience and knowledge to give the best to the patient, rather than going 2 by 2 plus 4. So thanks, Shumon. Thanks to all the faculties from home and overseas, and especially the juniors had the courage to talk on TNBC metastatic with all the seniors. They have really done a great job. And thanks to Zakir Bhai, John, and Varun. Thanks for joining. We really enjoyed all of you participation. Thank you.
Thank you. So as you know, we have to declare our winners, last week winners. So I'd like to request Tania, please, can you please share the name of our last week winners? So our last week winners are Dr. Sonia, Dr. Surya Sultana, and Dr. Hassan Shariar Kollol. Congratulations. I hope you will get your prize within a very few days. So thank you. I would like to give a special thanks to our academic partner Roche for giving us the opportunity to conduct this sort of program. And at last, I would like to request our chairperson, Professor M.A. Heiser, to say a few words and conclude this session. Over to you, sir.
Thank you, Shimon. We are at the end of today's session. I'm very happy that participants from locally, Dr. Umina and Aditi, did a very good job. First, they are the first appearance today, I think. Hopefully they will be continuing this participation in future as well. My heartfelt thanks to Dr. Burun, where possibly he joined us first time, and also John and Jacqueline. My heart thanks to the participants who took part, but I expected that more participants take part in our poll questions. Request our participants in future to participate in other poll questions in future. Thank you all very much. Goodbye, everybody. Good afternoon.
Thank you. Assalamu alaikum.